Hello, let's talk about malformations of the CNS. There are two different lectures that I have on this, and the first one's pretty easy. It's just a vocabulary test. The second one requires you to make some differentials. From this first SDL, there is going to be a question about open spina bifida. There are a few different subtypes of that. There's a myelocele, in which it's a herniation of only the spinal cord. And then there's a meningocele, which is a herniation of only the meninges. And then there's a myelomeningocele, which is a herniation of both involved structures. And so, again, vocabulary test. They will tell you in the question stem exactly what has herniated out of the spine. And then you're just going to pick the word corresponding with the appropriate diagnosis. Another question that you will get from this particular text will be about the split spinal cord syndromes. There's a Diastematomyelia, and then there is also a Diplomyelia. And the difference between the two of those is that a Diastematomyelia has kind of a bony protuberance in between the two different split spinal cords. And so there will be two separate dural sheaths, one around each cord. Whereas in a Diplomyelia, the split cords, so cord A and cord B, cord 1 and cord 2, cord Mario and cord Luigi, are both in the same dural sheath with no bony protuberance splitting them apart. So you need to know those vocabulary words. Again, this is just about one of the easiest SDLs you will ever have if you just memorize the words. Understand what they mean. Neural tube defects, this whole primary, secondary neurulation, all you need to understand is that primary neurulation basically refers to the formation of the brain, and that secondary neurulation refers to the formation of the distal spinal cord after the basics of the brain have been put into place. You must understand why folate is important to neurulation. So if there's a folic acid deficiency in a mother, her child is far more prone to developing a neural tube defect than if she were folate sufficient. Here's the reason why. It's DNA synthesis. Whenever you're making organs, organogenesis, you're undergoing, if you're the baby, a huge degree of mitosis. So to do that, for your cells to divide so much, they need all the precursors for DNA. So what do they need? They need sugars, deoxyribose, right? They need a lot of phosphate, and they need a bunch of nucleotides. So they need the whole shebang. They need the A, the G, the C, and the T. They need the purines and the pyrimidines. And once you know it, folate is involved particularly in the synthesis of thymidine. It's a cofactor for this thymidylate synthase enzyme, which takes deoxyuridyl monophosphate, DUMP, and flips it, methylates it into deoxythymidine monophosphate. And that's where you get the T in your DNA. So if you have a vitamin B9 deficiency, you're not making enough DNA. Thus, mitosis isn't happening like it should be. So that's the mechanism. How do you get folate deficient? Well, maybe you're not just getting it from your diet. It's in leafy greens. Some people haven't had a leafy green in years. I know, hard to believe, right? But it's the truth. So it's in spinach, it's in cruciferous vegetables. But besides dietary deficiencies, there could also be malabsorption. So patients with something like Crohn's or not ulcerative colitis, the small bowel is not really affected there. Crohn's disease, or maybe something like celiac disease, in which you just get a flattening of the gut and you get this big time malabsorption. Maybe B9 is a little bit low in that patient. There are also some drugs, some pharmaceuticals that can lower folate absorption from the gut. Those would be your anti-epileptics, valproate and carbamazepine. How they work is they simply interfere with absorption of vitamin B9 in the jejunum. And you need to know that's where B9 absorption occurs, as opposed to B12, which causes similar symptoms to B9, but is absorbed in the terminal ileum. And then, so those are anti-epileptics, right? Patient has seizures, you give them Valpro, carbamazepine. They want to get pregnant, they need a big time folate supplement. But then finally, there's trimethoprim, which is a dihydrofolate reductase inhibitor, and you recognize this as TMP. namely the TMP and TMP-SMX, which is the #1 drug, the frontline drug that we use to treat general urinary tract infections. We also use it as prophylaxis in HIV/AIDS patients. So TMP inhibits folate synthesis. A lot of ways you can get folate depleted. Let's talk about different neural tube defects now. First, there are open defects in which the spinal column fails to kind of close along the posterior midline. The first example of this is called cranioraschisis. So cranio meaning head, rachia meaning spine, schisis meaning split or fissured, and that's the same root as in the word schism or schizoid. So recognize this because it will show up again when you study the gastrointestinal tract. There's a concept called gastroschisis, which is, you guessed it, the anterior midline is split open and patient's bowels are protruding out of that fissure. So schisis means split, and you could have a pure rachis, which is just the spinal cord split open without the cranial involvement. And then there's anencephaly. Encephaly refers to the brain. Anencephaly then means that the brain is absent. And in anencephaly, the calvarium, or the skull cap, the top of the skull, is also absent. So this is going to, they have to tell you that that's there in the diagnosis again. So be able to tell this apart from a cranioraschisis is my point. Then we talk about spina bifida aperta. Spina bifida, bifid, means two. It's bifurcated, same word, same concept. So if your spine has two tails to it, if it's bifurcated, that means it's empty in the middle. It doesn't close properly. How your vertebrae form is you get the body and then you get some transverse arches and then they make an arch in a spinous process. And so they go from lateral to medial. And so if they don't meet in the middle, then there is room in between that bone for the spinal cord to just pop straight out. And so that leads to open spina bifida. Spina bifida, again, meaning the vertebrae don't close all the way, so there's two little tails to them instead of one arch. Different pathologies, different names of pathologies that you can see in an open spina bifida are myelomeningocele, which means that meninges and the spinal cord are popping out. There's myelocele, which means just the spinal cord is exposed and that the meninges haven't even formed correctly around the spinal cord. And then later on, there is a meningocele, which means that the meninges, the dura and arachnoid mater, herniate out of this open spine, but the spinal cord does not. And so they'll tell you exactly what has herniated out of the spine, and then you'll have to say myelocele, meningocele, myelomeningocele. Easy question. The only way I could picture them asking a higher order question is if they give you a case of a myelomeningocele and then they say, what else does this patient probably have? And the answer to that question is a Chiari 2 malformation. Understand Chiari 1 and 2 malformations are cerebellar herniation syndromes. And in a Chiari 1 malformation, one structure is herniated downwards through the foramen magnum. In a Chiari 2 malformation, two structures, the tonsils and the vermis of the cerebellum, have herniated downwards through the foramen magnum. So if you have a Chiari 2 malformation, it is highly likely that you also have a myelomeningocele down in your lumbosacral spine and vice versa. That's really what they want to ask you about this pathology. Here it is in the text. The large majority of cases of spina bifida aperta, aperta meaning open, are associated with Chiari type 2 malformations. Here you're looking at this kid's brain. Both of these pictures. On the left, it's popping out of the posterior fossa. On the right panel, it's popping out between the eyes. So that includes cerebral cortex right there, and that's just going to be similar to spina bifida, but in the skull. The skull doesn't fuse properly, so there's an opening. And so when the brain's growing, it just grows straight on through that opening because there's nothing to contain it. Then we have closed neural tube defects, which is not as severe a group of diseases as open neural tube defects. So the name for the closed defect is Spina Bifida occulta, occulta meaning unknown or not seen or obscure. And straight up, the way to know that there's a closed spina bifida going on in a patient is if they have some sort of mass or tuft of hair, maybe a tail or a hemangioma, or even something as benign as a port wine stain or a birthmark that's midline in the lumbosacral region. That means you you got a good doctor's intuition that there is a closed spina bifida occulta associated with this cosmetic malformation. Now, in terms of different types, you really want to know split cord malformations. Again, diastematomyelia means there's literally two stems, diastem. Okay, so therefore, there are two different dural stacks in this condition that begins with dia or two. So the reason why there's two separate dural sacs is going to be because there is a bony prominence or protuberance splitting these two cords apart from one another. That's the diastematomyelia versus a diplomyelia, in which there is no bone in the center of the spinal cord. It's just two cords with a thin membrane in between them, contained in one dural capsule. So that's the big difference between these two pathologies. There's bone in the middle of the diastematomyelia, and there's two separate dural sacs. And there is no bone in the middle of the diplomyelia, and there's one dural sac. And as I recall, in this question, when they ask it, they give you imaging. They don't tell you with words. They show you and they see which of you guys can read the thing, okay? So, and usually you don't need imaging to answer the question. Well, let me rephrase that. If you see histology, you usually don't need the histology to answer the question. But if you see an X-ray, you usually need that, you know? Point being, a lot of questions you can answer without the picture. There's a lipomyelomeningocele, which is like literally a lipoma. So that's not difficult. There's a hydromyelia, and they'll never ask you about that. The only reason you would ever see hydromyelia on an exam is as a confounder or a distractor to try and confuse you between that and Syringomyelia. You got to know this, got to know this. Then there's tethered cord syndrome. You might see a question on this. Patients typically present in the second or third decade of life, and they'll just say, man, doc, this sciatica that I've had my whole life has just gotten worse and worse and worse, you know, and I used to be an athlete. I used to be able to run around, but now it's like I can barely do anything. And if you scan the spine with an MRI, you get a soft tissue scan because you need a soft tissue scan to pick this up properly. You can't just x-ray it. Then you're going to see that maybe this patient's got a big, thick filum terminale, which is a soft tissue structure that adheres the tip of the spinal cord to the terminus of the dura down at the sacral base. So if this patient's got a big fibrotic filum terminale, all of a sudden that structure that should be like a rubber band is now like a steel cord. And so whenever they bend forward in flexion, their spinal cord there's a lot of traction there, and there's a lot of pain associated with that traction. And so again, this tends to present a little later in life, not like immediately like these other ones. And something important I highlighted is that in a newborn child, the conus medullaris, which is the tip of the spinal cord, terminates at about L2, L3. And then a couple of months later, as the baby ages, the spinal cord, its tip ascends to the L1, L2 level. And so this is important because when we are doing an LP, a lumbar puncture, on a brand spanking new baby, then we have to aim a little bit lower than if we're doing that LP on anybody else, and it's because that conus medullaris has not ascended yet. And so why would we do an LP? Well, meningitis is a great reason. And then intracranial, extreme intracranial pressure, you know, if there's a hydrocephalus and maybe we need to place a shunt, but like we'll LP first to just get some fluid out of the ventricular system. Those are both very good reasons. Something like strep agalactia, you know, like that can present as meningitis in the first week of life. So that's when you would need to aim lower. Talked about occulta. Last thing we'll mention in this SDL, alpha fetoprotein is elevated in neural tube defects, but specifically in open neural tube defects, it's going to be the very highest. So something like anencephaly or cranioraschisis, those are open neural tube defects, or something like a myelomeningocele. So how this question could get asked is like, mom has an elevated alpha fetoprotein. Which pathology does baby most likely have? And then they'll give you 4 closed neural tube defects and 1 open neural tube defect. And that's how you would have to know that open neural tube defects are the reason why alpha fetoprotein gets elevated, because it just leaks out through the placenta into the amniotic fluid into mom. So that is the first SDL on central nervous system malformations. Let's crack into this second one. I can tell you that you'll see a neuronal migration disorder question. A couple of variants of that are Lissencephaly and polymicrogyria, and then within Lissencephaly there are 2 subtypes. So that's 3 kind of similar looking pathologies, and we'll talk about how to differentiate those. I can assure you, you will see test questions about Chiari type 1 and type 2, Dandy-Walker, and Joubert syndrome. That's like A, B, C, and D right there, okay? So you'll get the imaging again, or maybe they'll give it to you in words rarely, and you'll just have to know these 4 cerebellar herniations apart from one another so that you can properly diagnose what they give you, because they're going to make it an easy question. It's so easy. But it's only easy if you know what you're talking about. Otherwise, good luck, you know, like you got no hope on it. So understand a Chiari 1 versus a Chiari 2 versus a Dandy-Walker versus a Joubert. And then I would say you'll get a question on a Syringomyelia, real easy there. That's going to be a dilation of the central canal of the spinal cord. And because that central canal is dilating, well, you understand that you have these spinothalamic tracts that enter the spinal cord at the same level that they innervate, and then they immediately decussate or cross over, and then they run up the contralateral spine. So that decussation of the spinothalamic tracts is right next to the central canal. So if you have a Syringomyelia in which that canal is dilated, the first structure that's going to get some pressure on it is that decussation of the spinothalamic pathways. And so in Syringomyelia, you see a characteristic loss of pain and temperature sensation bilaterally. Not a lot of stuff does that bilaterally. And it's typically going to be in the upper extremities first, and it's going to descend. And so then as the dilation grows larger and larger, maybe your anterior horns get involved, you start seeing some motor symptoms. And so they could throw ALS in there as an answer choice, but it's not that. It's going to be this patient who, again, can't feel hot and cold on their hands. So maybe it's like a metal worker, someone in a factory, and they keep burning themselves, or maybe it's a cook and they keep cutting themselves and they have no clue. They're like, doc, I've got 5 Band-Aids and I don't know how I got any of these. And so that's a Syringomyelia, loss of pain and temperature bilaterally. So that one's an easy diagnosis. You got it. Other than that, it's a big vocabulary test similar to the first SDL. Let's get into it. 4 brain abnormalities. Holoprosencephaly. Well, holo means whole or one. And prosencephalon, well, that's the forebrain. And so that's what you have before the brain divides into hemispheres. So, right, you have a left and a right hemisphere. Some people are left brain. Some people are right brain. Some people are big brain. Some people are small brained. Some people are no brained at all. They just live with their hearts. And holoprosencephaly means you've got one brain. So it doesn't divide into 2 hemispheres. You've just got one big hemisphere. A couple of associations. Number 1, fetal alcohol syndrome. Number 2, Pateau syndrome, trisomy 13. Now, When you see holoprosencephaly, you are probably also seeing in these patients midline facial defects, because division of the brain into two hemispheres occurs at the same time as midline facial structures are formed. So if there's a problem at this point in time, you will see abnormalities in both division of the brain into hemispheres and midline facial structures. Here it is in the text. Normally, the forebrain is formed and the face begins to develop in the 5th and 6th embryonic weeks. So if they want to ask you, when did this happen? It's weeks 5 and 6. So midline craniofacial abnormalities. Best cases, there's no abnormalities at all. A little bit worse than that would be like a cleft lip or a cleft palate. And then at the other end of the spectrum, maybe you have a single eye, cyclopia, or maybe there's a tubular nose, right? You're not going to get 2 nostrils properly. So a big range of craniofacial anomalies that you see here with holoprosencephaly. Why does it happen? Because of a mutation in the sonic hedgehog gene, which is very important for telling neurons where to go. So again, both the brain and the face are involved because those two structures are growing together in weeks 5 and 6. Then there's olfactory aplasia. Let me tell you, like, could you imagine writing a question and being like, okay, I got a class of 150 students. Here's my question. The patient can't smell. And then it's like you give them 4 answer choices. It's like, I can't ask them that. That's way too easy. You know, it's like it literally tells you what's wrong. Olfactory aplasia. How are you going to ask this question in a way that like it's even possible to get wrong? Okay. So you're not going to see that. You're also not going to see agenesis of the corpus callosum. Why? Because there's just about no way at all to ask what's wrong with this patient without telling you, hey, they don't have a corpus callosum. Like, you need to know that to make the diagnosis. So if you get a question about either of these two things, just smile and collect your check and read it twice to make sure it's not a trick question. But other than that, vocabulary test, know what you're looking at and you got it. Actually, now that I think about it, you might get asked this question just to see what knucklehead in your class is going to put something other than, oh, there's no corpus callosum there, because you got to know the corpus callosum is kind of suprathalamic, right? Right? It's not like right here at the bottom of the brain. You know, that's not where you find the corpus callosum. So if you're looking at this axial slice, you're not going to look at the bottom of the brain and point at this thing here and say, oh, gee, well, they have a corpus callosum. Hey, you didn't learn that from me. Corpus callosum should be right square in the middle of the brain, okay? It shouldn't be up here. It should not be down here. It's smack dab in the middle. A lot of visual diagnosis on this test, you know, with the rachis, cranioraschisis anencephaly. Again, they're going to want to know if you can tell the difference between these similar terms, because anyone can look at these neural tube deformities on any scan and say, oh yeah, there's a problem there, you know? So which one, like Life of Pablo, which one? That's the point of this test. Here is a tricky section. Disorders of cortical development. And what you've essentially got is you're a quarterback and you've got these dumbass wide receivers who are not running their routes. And so you're ready to throw it and they're just not there. So these neurons are not running their routes properly. They end up in the totally wrong parts of the brain, right? You call crossing patterns and they run streaks, okay? You call slants and you call a 16 power O and your running back is off running a wheel route. You're like, what are these guys doing? So the neurons are all messed up. And first, we got some size problems and then we got some quality problems. So quantitative problems, you have too many or too few neurons, and then qualitative problems, they're not going where they ought to be. So quantitative neuron problems. Megancephaly, you have too many neurons. The brain is greater than 2 standard deves above the mean for age and sex in terms of head circumference. And they might really want to know that head circumference part. So you need to know it's particularly head circumference. That's how we measure megancephaly. Then there's hemimegancephaly, which you can only really diagnose on a scan. It's going to be one side of the brain is big and the other is relatively normal sized. You also see ventriculomegaly with this. Microcephaly, the brain is abnormally small as based on head circumference, less than or greater than 2 standard deves below the mean for age and sex. So those are size problems or quantitative neuronal problems. Then we have qualitative neuronal problems, disorders of neuronal migration. This is a little tricky. There's 2 types of lissencephaly, and then there's polymicrogyria, okay? We're gonna chop this up as best as we can so that you can make this differential every time. Lissencephaly means smooth brain. Polymicrogyria means many small gyri. So it's a bumpy brain. So right off the bat, classic lissencephaly and polymicrogyria, you have no problem there. It could not be easier to tell these 2 apart. But there's one in the middle, okay? And it's called cobblestone lissencephaly. So I don't get it. Don't ask me why, but they call this thing bumpy smooth brain. So it's not smooth, it's bumpy. They clearly tell you the brain has a cobblestone appearance, which means that if you see a picture of it, you might get it confused with polymicrogyria. So the way to tell them apart is to biopsy the brain and take a look at the cortex under a microscope. And what you see in cobblestone lissencephaly is that, quote, the cortex is severely disorganized with no recognizable layers, versus polymicrogyria, quote, typically the cortex is unlayered or has 4 layers in contrast to the normal 6 layers. So if they want you to really tell the difference between the 2, that's the only real difference between them that I can put into words. Now, as I recall, this is another show you the picture question, and then they ask which one. So know these pictures in your SDL cold, because sometimes they put the same exact photo on the test, the same one that is in your lecture. And it's like, why? Well, it's like, well, how many different gross biopsies of polymicrogyria are out there? You know, it's like we only got so many photos on Google Images. And so they do tend to reuse these gross pathology photos. Taking a good look at this, polymicrogyria, many small gyri, creating excessive folding. That's big, 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 big. Excessive folding, okay? So they might show you this and tell you in the question stem that there is excessive folding. And then there's a pachygyria too, which pachy means large, like pachyderm. That's like an ancient mammoth. So pachygyria, large gyri. So there's going to be a lesser number of gyri in pachygyria, and they'll be swollen up. So this is simple to understand, but tough to diagnose. So go look at some images of polymicrogyria, lissencephaly. That's my best advice to you. Now, breaking these down a little further, just in case, the difference between the 2 types of lissencephaly. Classic lissencephaly is an undermigration problem, and what that means is that you have these neuronal stem cells, but there's a defect in their microtubules, and so they just can't get to where they need to be going. They know where they're supposed to be going, but they just can't get there. Versus a cobblestone lissencephaly, in which there's nothing wrong with the stem cells. They're totally fine. In fact, they over-migrate. But the problem here is that they have no clue where they're going. And that's because the way they know where they're going is going to be chemotactic cytokines released by glial cells, and the glia is just the periphery container of the brain. So if the glia can't talk to neurons and tell them where they're supposed to go, well, then that's where your neurons end up in places that they have no clue where they're going. They just know they need to go somewhere. So that's a cobblestone lissencephaly. Now, this classic lissencephaly is associated with this double cortin gene DCX. It's X-linked, it's on chromosome X, and it's inherited in an X-linked dominant manner. And I'd like you to know that classical lissencephaly is what guys with the double cortin mutation get. And if you're a girl and you've got a double cortin mutation, you're not getting classic lissencephaly, you're getting this thing called subcortical laminar heterotopia. So same gene, but because it's X-linked, remember typically women don't really get X-linked disorders because they have two X chromosomes, right? But if it's X-linked dominant, then sometimes you can see some phenotype in women. And so here it is, it's called subcortical laminar heterotopia. And well, I don't have too much to say about that. I've about expended my usefulness in this section about neuronal migration. All that I particularly remember is that when you get this question, there's going to be a picture attached. So please go look at, Robbins Atlas, go look at Google Images, find as many different angles to look at these pathologies as you can, because there will be a photo associated with it on the test. Now we've got posterior fossa malformations. There's aqueductal atresia. That just means that you really don't have a Sylvian aqueduct, which remember is the structure connecting the third to the fourth ventricle. And when we're at the level of the cerebellum, we're talking about the fourth ventricle, which also has foramen magendi and foramen elushka that are lateral, L for lateral. So that's where we're at right here. Atresia means the aqueduct's a dead end, so that's a really, really bad obstructive hydrocephalus. You got to shunt those patients and figure out a way to correct that atresia. Then there's aqueductal stenosis, in which it's there, it's just too skinny, so you'll probably have a hydrocephalus there as well. You could get aqueductal gliosis. So again, a glial cell is a supportive, it's a non-neuron basically. If it's a cell in the brain that's not a neuron or an immune cell, it's a glial cell. And so a gliosis is just a reactive proliferation of glial cells. How could you get that? Well, maybe you have a meningitis and there's some post-infectious scarring, maybe of your choroid plexus or of your ependymal cells in general, and so those cuboidal cells get all scarred, and all of a sudden you've got a stenosis of the Sylvian aqueduct, or just about any other part in the spinal canal. It could happen there too. Now we talk about Chiari malformations. You'll see a question on this. The way to tell them apart is that in a Chiari 1, there's one structure involved, and that's the cerebellar tonsils. In a Chiari 2 malformation, there are two structures involved. There's cerebellar tonsils and the cerebellar vermis. And so what's identical in both Chiari types is that something in the skull is herniating downwards through the foramen magnum into the spinal canal. And that something is, in a Chiari 1, the cerebellar tonsils, just one thing. And in a Chiari 2, the tonsils and the vermis. So associations, they want to give you the diagnosis. Maybe you have to look at a CT, make the diagnosis, then it's a second order question. They ask, what's the association? Love to ask that. Understand, Chiari 1 is strongly associated with Syringomyelia. So that's that loss of bilateral pain and temperature, typically upper extremities in a cape-like distribution. Chiari type 2 malformation is associated with open spina bifida, namely the myelomeningocele. So that means that both the spinal cord and the meninges are herniated out through this vertebral bone that did not close properly, did not make an arch properly. So there's two Chiaris, which have the same mechanism, downward herniation of the cerebellar contents through the foramen magnum. one structure in a type 1, 2 in a type 2, and there's a different association for both of them. That's all you got to know. There is a Chiari type 3, which has an inferior displacement of the medulla, which is the lowermost part of your brain stem, alongside an encephalocele. So an encephalocele, what's that? Well, it's essentially a hole in the skull, and part of the brain is going to bulge through that hole, and it could be in the front. We'll call that a cervical, or in the back, we'll call that an occipital. I'm sorry, front, we'd probably call that frontal or nasal. So you have an encephalocele alongside a downward herniation of the brainstem. It's a Chiari type 3. It's the only one with an encephalocele. Chiari type 4, I have never heard of that. I've never seen that. Not once. You don't need to know that. Here it is again. Now, listen to me. This applies to every SDL you will ever read. If it's in there twice, you better read it twice. If it's in there 3 times, you better read it 3 times, because if it's in there 2 or 3 or 4 times, you bet it's going to be on the test. Here it is again. Chiari type 1 associated with Syringomyelia and hydromyelia. Chiari type 2 associated with myelomeningocele. So they already told you this, but now they're telling you again. Why? Because they want you to know it. Chiari 2, let's see. How do you tell them apart? When do they present? In Chiari 1, symptom onset is insidious, like that mid-2000s horror movie, and patients usually become symptomatic in adolescence or adulthood. The mean age is 18 years of a Chiari 1 at presentation. Chiari 2 is usually detected prenatally or at birth because it is nearly always associated with a myelomeningocele. What do you know? They just said it a 3rd time. They want you to know that. The diagnosis is based on gross structural abnormalities. What does that mean? It means most times they ask you about this, there will be an associated CAT scan or MRI. Now we're on to a couple of similar pathologies that are similar in that they're downward cerebellar displacement syndromes, and they're called the Dandy-Walker malformation and Joubert syndrome. And so the typical question is the kid or the young adult who comes in with the downward cerebellar herniation, and your answer choices, before you even read the stem, you know the answer choices are going to be Chiari type 1, Chiari type 2, Dandy-Walker, Joubert syndrome. So you got to know all of them apart from one another, and especially know the associations. Because guess what? There's even an association with the Dandy-Walker malformation. So a Dandy-Walker malformation is going to be the most common, actually, out of all of these different cerebellar herniations. And it's characterized by agenesis of the vermis. So there's going to be a dilation of the 4th ventricle and an enlargement of the posterior fossa. So let me walk back something. Dandy-Walker, actually, I don't think that you do have a herniation with it. You need to memorize that it's agenesis of the vermis. So no herniation, unlike the Chiaris, but it is an agenesis of the cerebellar vermis. So there's a little bit more space for that 4th ventricle to expand and fill with fluid. So as a result, you usually see compression of the cerebellum that can lead to an ataxia. And you could see a hydrocephalus caused by atresia of the foramina of Luschka and or Magendie. And remember, Luschka, L lateral, 4th ventricle. So the association with Dandy-Walker is hydrocephalus. What does the patient probably also have? Hydrocephalus. And there's agenesis of the vermis. So they'll either give you the patient with agenesis of the vermis and say, what's this patient most likely at risk for? Or they'll give you the patient with hydrocephalus and they'll show you a scan, and there will be a big nothing in the 4th ventricle. The 4th ventricle will be huge because there's no vermis. And then they'll say make the diagnosis, and that's Dandy-Walker agenesis of the cerebellar vermis. And then there's Joubert syndrome, which is cerebellar vermis agenesis combined with a brainstem malformation. If they ever want to ask you about this, they'll give you this molar tooth sign, in which this is your normal brainstem with a central canal, right? And a couple of cerebral peduncles right there on the front, so we're in the midbrain. But it does kind of look like, you know, if you just reached in the back right corner of your mouth and just like pulled that tooth out and held it up and looked at it, it looked exactly like Joubert syndrome. So that's really what you need to know for that. If they want to ask you about this, then they're going to give you that. The gene is called Jouberin, convenient, because it's a cerebellar problem. You don't have a vermis. Of course, there's ataxia. And also a corticospinal tract problem. No associations with this one. Okay, so Joubert syndrome, you got big molar tooth sign. Dandy-Walker, agenesis of the vermis. Chiari type 1, one structure, cerebellar tonsils herniate downward. Chiari 2, two structures, tonsils and vermis herniate downwards. So 2 of those you have a vermis, 2 of them you don't. If it's Joubert, they'll give you a molar tooth sign. Know your associations. Finally, Syringomyelia. And we've also got hydromyelia, but listen, they'll never ask you hydromyelia. It's going to be a Syringomyelia. If in some anomaly, they give you a patient with a dilated central canal and they have no symptoms, no neurologic deficits, then you are allowed to say hydromyelia. You have my permission. But other than that, if the patient's got any symptoms at all and they say anything about dilation, it's going to be a Syringomyelia. So this is associated with a Chiari 1. And again, spinal thalamic neurons decussate as soon as they get in the spinal cord. And typically this dilated structure interferes with those neurons, which is why you get the loss of pain and temperature sensation. Most lesions are in the cervical and thoracic spine, which accounts for the cape-like distribution that is classic. You want to know that associated Chiari type 1. Looking at these photos. Okay, I do have something very relevant to add that's going to help you make this diagnosis, because now that I recall, this is another one they just show you a photo on. This is such an image-based exam, so please, if it's morning of your exam, spend your time looking through Robin's Atlas of Pathology to try and find out, or Rubin's, something, one of those are names. Try and figure out what all these different things look like. That's going to help you more than reading words about them at this point. So a big difference between Syringomyelia and hydromyelia. Hydromyelia is always in the center or in the middle of the spinal canal. You will not see hydromyelia off to the side like this. But a syrinx is kind of like a spinal cord version of a cyst, and there's really no rhyme or reason. Syringomyelia tends to be the central canal, but it's not exclusively the central canal. So if you see a little cystic dilation off to the side, if it's off center, then you're going to call it a Syringomyelia, indubitably. So that's the last big differential I have between the two. Lots of acquired causes of Syringomyelia. Hydrocephalus could create one. Again, just that intracranial pressure is going to be forcing the brainstem downwards, and that could again cause this cystic space to kind of develop within the spinal cord. Could be due to infection, anything that gets into the spinal cord. Could be an autoimmune type of process, such as MS, right? That's a type 4 hypersensitivity, or transverse myelitis. I believe that that's something like polio or Guillain-Barré. When I hear transverse myelitis, I associate it with bilateral neural deficits from a certain spinal cord level down. And so the itis means it's an inflammatory process. Anytime you see itis, what that means is white blood cells are involved in the traditional inflammatory process. Post-traumatic, that makes a lot of sense. And different tumors, if they're going to compress a region of the spinal cord, again, that's just a pressure thing at that point. It can shift some fluid over. Maybe there's a fluid leak from the central canal due to pressure. Maybe it leaks into a different region of the cord, and then bang, you get a separate little column of fluid besides the central canal. So lots of ways to get syringomyelia. Here is what I think is the big takeaway from this section. Loss of the ability to feel extremes of hot or cold in the hands is frequently seen, and again, usually bilateral. Hydromyelia, one more time, no neurological deficits. It is square in the middle of the spinal cord, and it's dissociated with any of the cerebellar pathologies we just talked about. So one more time from this whole second SDL on CNS malformations, what are you going to get tested on? You will get a syringomyelia versus hydromyelia question. You will probably get a Dandy-Walker versus Joubert syndrome question. You will get a Chiari 1 versus 2 question. I think you'll get a neuronal migration question. And that's a tough section. Wish I had more to say on that. And then finally, I think that you will see probably 3 cerebellar malformation questions from that one section, or maybe a holoprosencephaly. And so that is structural malformations of the central nervous system. There's a lot of them. Expect so many images. Expect an image on just about half, at least half of the questions that you see on this path test.